This is Group 5's presentation on workplace violence. What is workplace violence? According to the National Institute for Occupational Safety and Health, workplace violence includes acts of physical violence or threats of violence directed toward people on duty or at work. We reviewed a case study about workplace violence by Stephen Bowman and Eileen Levy. The case study takes place in a moderate-sized nonprofit community hospital in the New York metropolitan area. It was found that hospitals and clinics in the area have become increasingly stressful, unpredictable, and hostile places. The case study puts the responsibility on the facilities to provide safe working environment for their workers. However, it is the responsibility of the individual to report workplace violence. The case study suggests ways to reduce workplace violence in high-risk areas such as emergency rooms and psychiatric units. Workplace violence affects nurses in different ways. For example, nurses who sustain injuries from patient assaults may suffer psychological trauma, be out of work for periods of time, have financial problems, show decreased work productivity, make more errors at work, and report a decreased desire to remain a nurse. Others may report feeling less able to provide appropriate care to their patients. Ethical principles and dilemmas regarding workplace environment may include patient and employee safety. When we think workplace violence, we may only think about staff. However, patients in the vicinity are also at great risk. Workplace violence is not only physical, but can be in the form of abusive and offensive language. Patients are the number one group responsible for inflicting violence upon healthcare professionals as well as other patients. Nurses responding to stressful situations. The lack of preparedness or a nurse's experience can lead to them falling victim to an aggressive patient. These violent behaviors can be preventable with a proper aggressive risk screening and management strategies. Assessment tools such as the STAMP Violence Assessment Framework may be helpful. STAMP stands for Staring and Eye Contact, Tone and Volume of Voice, Anxiety, Mumbling, and Pacing. Nurses who work on a unit such as a med-surg floor may not have as much experience dealing with violent patients as a nurse working in the emergency room or behavioral health. Screening tools such as STAMP can be helpful and prepare the nurse for the unexpected. Lack of ongoing self-defense and violence prevention education. The case study hospital doesn't provide its staff with prevention education. Prevention education will help nurses be better prepared for the unexpected situation. The lack of prevention education falls in the lap of the leaders, the managers, directors, and nurse educators. Management staff is responsible for recognizing the need for education as well as taking the appropriate measures to implement such policies that will assist in keeping its staff as well as patients safe. This dilemma also falls under the category of lack of leadership at various levels. Lack of hospital leaders to take the proper steps in bettering their hospital jeopardizes the safety of everyone from violence in the workplace. Reduced number of psychiatric beds and release of mentally ill persons from public hospital without adequate outpatient programs and follow-up care. Psychiatric patients are being discharged from hospitals too soon without the proper recommendations and follow-up care. Early discharge due to lack of beds is resulting in the decline of mental status for psychiatric patients. Negative outcomes include readmissions into the hospital, risk of violence, risk of suicide, and disturbed family life. Given these serious negative outcomes after discharge, one is led to wonder if acute psychiatric hospitals should not last longer, in an attempt to reduce setbacks. Brief hospitalizations are producing a revolving door pattern and not addressing the root problem. Reduced outpatient and inpatient addiction services. Once discharged, patients are not provided with the proper resources to maintain adequate care. Patients are not ill enough to remain an inpatient but require the follow-up and maintenance professional help. The dilemma lies with the creators of these programs, whether it is the lack of resources, funding, or staff. The patient then enters into a vicious cycle of inpatient hospitalization to being discharged prematurely with no outpatient services. The lack of resources leads to return of negative behaviors and ultimately regression. The accessibility of handguns and drugs in the communities. The neighborhood in which the hospital resides will directly correlate with the types of patients and types of admissions you will see. If there is a high incidence of drugs and weapons in the community, you will see more violent patients and the risk of workplace violence increases. The drug-related attacks and injuries will bring in the patient and families who present a higher risk. The root of the problem lies with authorities and government officials to clean up the neighboring streets. What are the key healthcare provider responsibilities? Are there guidelines or policies to guide healthcare providers? Healthcare provider responsibilities can vary depending on the patient population that is being served. According to the case study, healthcare provider responsibilities involve efforts to reduce violence in high-risk areas such as the emergency department and psychiatric units. This can be achieved by restricting access to these high-risk areas, using surveillance equipment, panic buttons, and a strict requirement for all staff to wear identification. Enforcing these types of safety measures is the responsibility of the healthcare provider. All hospitals should have a task force and regularly meeting committee consisting of management, human resources, employee relations, employee assistance program staff, security, and the Office of Chief Counsel with the sole purpose of developing policies and procedures to prevent and address workplace violence. Following the Joint Commission's lead, the case study hospital and nursing administrations have hospital-wide discussions and training on behaviors that undermine a culture of safety. In addition, the hospital requires workplace violence risk assessment, hazard prevention and control, and safety and health training, as well as a careful record keeping and program evaluation. In order to put patients' health and satisfaction first, the hospital needs effective leadership at the top and from its professional nurses. To prevent violence in the workplace, nurses need to strive to be as authentic in their patient contact as possible and to avoid detached impersonal interactions. When nurses have good communication skills, they are able to calm patients that are becoming violent. Nurses can de-escalate a situation or diffuse a potential act of violence by guiding the patient in a direction in a calm, gentle, yet direct approach. According to the case study, nurses need to be just as effective in managing toxic emotional environments as in handling toxic chemicals and infections. Nurses' interpersonal effectiveness is increased when they look for and support strengths in others. In order to gain insight into lessons learned from previous acts of workplace violence, it is important to have a debriefing. This helps transform the experience into a team-building and learning opportunity. Leaders should involve all staff and review events, including what precedes and follows an incident. It is also important that healthcare organizations provide referral information, such as employee assistance program or clinicians' experience in trauma care for employees who may exhibit more serious and persistent reactions to perceived violence and aggression. What is the effect of healthcare policy and healthcare economics on the quality, cost, and access issues related to the case? The effects of healthcare policies and healthcare economics on quality includes the assurance of job safety and security, overall safety and health program, administrative commitment, employee involvement, and conduct risk assessment. The effects of healthcare policies and healthcare economics on cost includes the need to purchase surveillance equipment, installation of panic buttons, purchasing visible identification for all employees, cost of hospital-wide safety and health training, and costs associated with the employment of an on-site employee assistance provider such as a psychiatric nurse practitioner. Access is affected by the reduction of the number of available psychiatric beds, reduction in addiction services, lack of self-defense program, and lack of violence prevention education and training program. Some of the regulatory recommendations includes OSHA's guidelines for preventing workplace violence for healthcare and social service workers, CDC and NIOSH's workplace violence prevention for nurses, and the Joint Commission standard which states leaders create and maintain a culture of safety and quality throughout the organization. There is no federal standard that requires workplace violence protections. Several states have a mandatory comprehensive prevention programs for healthcare employers, as well as increased penalties for those convicted of assault of a nurse and or other healthcare personnel. Our policy recommendations include creating policies based off of guidelines from regulatory agencies such as OSHA, NIOSH, Department of Labor, and the Joint Commission. These policies should include management commitment, employee involvement, worksite analysis, hazard prevention and control, safety and health training, and record keeping and program evaluation. This concludes our presentation. Thank you for listening.